So I think we are well in time. We can start from the first speaker, Dr. Hari Krishnan Mandali. Is there? Dr. Hari Krishnan. Next one, Dr. Narendra Wala. Narendra is going to speak on nucleus deliveries in SICS approach without entering in anterior chamber. Dr. Manish is there? Co-chair.
हाँ नरेंद्र वाला thank thank you AIOC for giving me opportunity. I will be discuss on topic of nucleus delivery in SICS approach without entering in anterior chamber. As we all know that in SICS everyone has their own modifications, so I have just little bit modification done in my nucleus delivery step. These are the all known delivery steps. Like the first one is pulling technique like Faco sandwich, fish hook technique, vectors delivery, pushing technique like visco expression, and hydro expression with regating vectors and Blumenthal technique. In our technique is similar with pushing technique with some modification. In our modification after visco filling below and above nucleus, we synchronize of pulling of superactus bridal suture with pressing of lower lip, which open the tunnel area and effortlessly nucleus come out from the anterior chamber. Benefit of our studies, we are not entering in anterior chamber, so less chances of DM detachment, PC RAN and iridodialysis. Limitations, need a bridal suture for every patient, should be avoided in pre-existing weak zonule like PXF patients, phagodonosis, and need a adequate tunnel size in hard brown and mature cataract. This one is video. Sound is edit. It's coming or not? You can play another separate video if this video is not coming. Close this one and just play the another some separate video. This above. Yes, correct.
This is a video representation of my approach to nucleus delivery in manual SICs without entering antechamber. Video demonstrates novel technique of nucleus delivery without entering in antechamber in different grades of cataract. So, this is a case of grade 1 nuclear sclerosis, in which only by pressing the posterior lip of the scleral tunnel by the vectis and pulling the superrectus bridal suture, the nucleus delivery can be easily performed without entering AC. This is a nuclear sclerosis grade 2, in which similarly, by pressing the posterior lip of the scleral tunnel and pulling the superrectus bridal suture, I have performed nucleus delivery without any entry into the antechamber. This is a grade 3 nuclear sclerosis in which I am performing nucleus delivery in the similar fashion. This is my nucleus delivery in hypermature cataract. It's a Morganian cataract. This is the use of the same approach in a mature brown cataract. So also in the hard cataract, nucleus can be easily delivered with this technique. This is in the mature cataract. I am delivering the nucleus with the same approach. This is in the mature hard cataract. I am using the same approach to deliver nucleus.
Thank you so much.
Thank you, Dr. Hari. Okay, next presenter.
It was a good presentation. Just wanted to know one thing. What about the corneal endothelium in cases of, the harder cataracts there, post-operatively?
Actually, we have not not done any specular microscopy, but cornea is clear. Post-op day, post-op 1 week, we see the clear cornea. There is no any edema, so there is no need for any specular because cornea was clear. So we don't need any endothelial counts.
Okay, thank you.
Yeah, thank you.
Next speaker is Dr. Amit Kumar Mahajan. Is there? Dr. Amit. Dr. Amit is there. I think next we can call Dr. Aarti Heda.
So, good
Basket of
afternoon, everyone.
complicated cataract, yeah.
Good afternoon, everyone. Sir, my
What
video
is
is of
there
8
in
minutes. My video is of 8 minutes because that's what I submitted to AIOC.
You can fast
So,
forward.
since the previous speaker has not come, maybe I'll take little bit of
You can
extra
just
time.
shorten it. Maybe you can just fast forward it.
What is there in
Sure.
basket of complicated cataract today? Be prepared to see surgical management of some complex cataract cases. Let's get started. Case 1 is of 32-year-old female with unilateral typical iris coloboma and cataract. Posterior segment examination was normal. Under local anesthesia, patient was posted for surgery. 2 side ports were fashioned and the main port entry was made. Capsule was stained with trypan blue dye. Capsulorhexis was made aiming at proper centration. Gentle hydrodissection was done. Phacoemulsification was commenced with low parameters. Thorough cortical wash was done. Capsular tension ring was then placed to support the area of zonular dehiscence. Intraocular lens was placed in such a way that haptic lie in the colobomatous area. 2 peripheral corneal stab incisions were made. 26 gauge needle was passed through the paracentesis and then the edge of the central iris leaflet exiting through the distal incision. Railroading was done using a straight needle on tenoproline suture and then it was tied using modified Siepser's technique. Try to avoid force and be slow, otherwise the suture may just cut through the iris tissue. One can use the micro instruments for better hold of these thin sutures. Viscoelastic was removed and the case was concluded. Post-operatively, patient had vision of 6/9.
Good. Backspace clear. Rock it out.
Second case, 26-year-old male presented with rapid onset decrease in vision of 2-week duration in the left eye. On examination, there was self-sealed corneal wound of entry, anterior capsular tear, and intralenticular iron foreign body with a mature cataract. 2 side ports were fashioned and the anterior capsule was stained with trypan blue dye. Here you can see the Argentina flag sign very clearly. Main port was made and the intralenticular iron foreign body was removed. Phacoemulsification was then commenced using low parameters. Viscoelastic was injected in the anterior chamber before removing the phaco probe. After assessing the extent of the capsular tear, the capsulotomy was attempted in order to have a circular opening. Single piece intraocular lens was injected in the bag and the case was concluded. Post-operatively, patient did very well with vision of 6/9. Moving on to the third case, which is of 53-year-old male who presented with inferior iridodialysis and subluxated mature cataract following trauma 15 years back. B scan was normal. After counseling, patient was posted for surgery. After conjunctival peritomy, bleeders were cauterized and scleral tunnel was fashioned.
1 minute it should be done.
Two triangular flaps were created at 9 and 3 o'clock position. After releasing the posterior synechiae, double-armed tenoproline was then railroaded through the dialyzed iris stroma and sutured under the flap. Subluxated cataract was removed and scleral fixated intraocular lens was then sutured to the sclera with the help of tenoproline suture. It is important to tie these knots really well, or else you can get wobbling of the lens post-operatively. With the haptics. Tenonylon suture.
Thank you so much, sir.
Nice, very nice presentations with good management of complicated cases. Just was wondering one thing, when you managed that Argentinian flag sign, I mean, you did phaco, and then later on you enlarged the rexis. You could have done that before because you were managing in a very narrow, area.
So the patient was very young, so the cataract was very soft. So I could have actually aspirated that. And since it was a mature cataract, it would have been difficult for me to assess the extent of the Argentina flag sign. So I thought that it will be better once I remove it. And since it was not a hard cataract, it was easy to manipulate the lens part of it.
Sometimes if you are not sure of extension, then I think lens will be better in the sulcus rather than in the back, because then it can extend further also.
Sir, I was operating this case in Africa where I did not have access for a 3-piece lens. So there was no way I could have put this foldable in the sulcus. The second thing was, since the patient was young, I assumed that the zonules will be strong, and I can go with the single piece lens in the back.
Thank you very much.
Thank you so much.
I think next present Dr. Rakesh Bansal. He is going to present an ICL implantation for unilateral high myopia.
Thank you, Dr. Arya. Can I have my presentation?
This is the
Yeah, keep
video
the sound.
of a patient, 20-year-old. She was unilateral high myopic. The corneal thickness was just 433. So she was not a patient for any laser vision correction. She was taken up for ICL implantation in the right eye.
You can see the patient was
Power of the
very high myopic.
glasses in the right eye was -10 with 1.5 cylinder. The The ICL toric was chosen for her. The loading of the lens is not very difficult. A soft tip is used. In the cartridge, you fill with the saline, followed by HPMC 2%, and then lens is taken out from the bottle with the help of a soft tip, and then lens is loaded into the cartridge as advocated by the company. See that both the edges of the lens are equal on both sides, and then with the help of a forceps, the lens is pulled into the anterior part of the cartridge, so just remains a little bit short of the tip of the cartridge. And after the lens has been mobilized to the tip of the cartridge, it is loaded onto the injector. So once the lens and the cartridge are ready, the eye is kept ready with full mydriatic. So two side ports are made, and then HPMC is injected into the anterior chamber. Never overfill the anterior chamber with the viscoelastic. A clear corneal temporal incision is given, which is about 3 millimeters. So now the ICL is injected into the anterior chamber very slowly. Once the 1/3 of the lens is in the anterior chamber, make sure that you keep your eye on the right lower haptic so that the hole in the right optic opens up in a right position. So you can see here the right tip has opened up in a nice way. And once you are sure, then you can fully inject the lens into the anterior chamber. Now once the lens is in the anterior chamber, now using a forceps, manipulating forceps, one has to see that you push all the 4 haptics right behind the iris. So slowly make the anterior chamber a little bit deep, never overfill the anterior chamber, then each haptic is slowly pushed behind the iris. So once the lens is behind the iris, you have to position the lens in the right axis. So now make sure, because this is a toric ICL, now make sure that the lens is in the right axis. So each haptic is carefully pushed behind the iris. And now you dial the lens to its desired position. So slowly, so that make sure that lens is in the right axis. So once the lens is in position, the anterior chamber is washed of the HPMC which has been injected. So use thorough irrigation and aspiration. Make sure that the anterior chamber as well as the viscoelastic is taken out from behind the ICL through the central port. So once the viscoelastic is out, inject pilocarpine into the anterior chamber so that the pupil constricts. Postoperatively, this patient did very well. The postoperative visual acuity was 6.6 with a clear cornea. Thank you very much.
Thank you.
Dr. Bansal, very excellent surgery. I think it was a very well done surgery. Thank you very much.
Patient had a very high amount of refractive error, so no other option was available. So she is very happy at 6.6 vision now in both the eyes.
Especially ICL, that also toric in young patient, it's
Yeah.
a very good option if you are not able to do refractive surgery. If your corneal surgery is not possible, then I think this is the best option.
So just one thing, I mean, like it's very important to know the white to white distance. So how do you measure that?
Yeah, I use 2-3 methods to do white to white. One is a caliper method. Okay, so we have a vernier caliper, so we can use white to white. And then I have the topography also. So we give data on all the parameters, and then the company decide which size of the lens which is to be implanted. So white to white, actually we use 2-3 devices,
Okay.
and then we know how much is the white to exact
So
white. To.
preferably, like which method would you advocate?
I'll advocate the caliper method, digital caliper method.
Right. Because when you do with the IOL master, the sizing is a little.
That is a little
larger.
higher, about
Yes.
0.5.
Yes,
it's
0.5
more.
to 0.6 it's higher.
Absolutely,
Yeah.
absolutely. Digital caliper is the best.
Is best. Yeah.
Some people use UBM also. If you can know the exact size of the sulcus, so that also can help. So in the absence of UBM, I think digital caliper is the best method to
Very
My
true.
experience also digital. I think that gives more accurate.
more
reading.
accuracy.
Even company also prefer digital.
Digital accuracy.
Only thing it's too huge, so when you place it on the patient's cornea, it's a little scary. But
Yeah, you need a speculum actually.
Yeah.
So never try to do without
No, no,
speculum
that
because
is
then
not
patient
possible.
keeps on squeezing. So
Yeah.
put a drop of paracane, use a speculum, and then patient is comfortable. Then you can.
Then better to do under microscope. Because
Yeah,
this,
magnification
it has to
definitely
be
helps.
Under
Yes,
microscope,
yes,
not
yes.
that without microscope you
Yeah.
cannot.
Absolutely.
Very
absolutely.
nice presentation. So our next speaker is Meghna, Dr. Meghna Reddy, and she'll be talking on unsung heroes of cataract surgery, the underrated fingers in cataract surgery.
Good afternoon, everyone. Most of us would have encountered dirty hands when we initially started off with our MSICS surgeries. What could be the reason for these dirty hands feeling dirty and exciting? It could be difficulty using instruments or it could be difficulty resting our fingers while operating. Cataract surgeries are microsurgeries requiring a high level of precision, and surgeons' hand positioning is very important. So keeping in mind the importance of promoting gentle precision. So there are certain ways we can position our hands to maximize success in the surgeries.
never been taught to us, and with experience we learn, how to maneuver things and do. So it's nicely, showed.
Thank you, sir.
I think for residents, it's very important. Those who do surgery in the initial time, I think controlling the hand is very, very important. Once you control the fingers, I think the surgery is almost done. It's a very good message for the audience. Thank you very much.
Thank you, sir.
So we call upon the next speaker, and it is Dr. Mallikarjun M. Haralgi, and he'll be talking on cannula for hydroimplantation of IOL.
Hydroimplantation is the implantation of IOL. Hydroimplantation is the implantation of IOL in the capsular bag under irrigating solution without the use of viscoelastic. What is the need? Retained viscoelastic after cataract surgery can cause postoperative inflammation, a rise in intraocular pressure, and toxic anterior segment syndrome, which leads to delayed postoperative recovery, leading to a greater postoperative patient discomfort. Few surgeons are performing hydroimplantation by using irrigation aspiration probe, but this cannot be done in coaxial IA. Some use hypodermic needle, but this is not a safe method since the sharp edge of the needle can cause damage to intraocular structures. Hence, no specific device is available. Considering this, we devised a cannula which is basically a 20 gauge stainless steel cannula with dimensions as shown in the figure. The tip is closed. There is a hole at the bottom of the cannula just posterior to the tip. One more hole is present at the side of the cannula. It is bent at an angle of 120 degrees, which will make insertion via the side port comfortable. The other end is attached to the irrigating fluid. Since the tip is closed, fluid can come out from the bottom and the side, which inflates the bag and the AC fully. Since the tip is blunt, the chances of injury to intraocular structures is very low. Cannula is being inserted from the side port and the bag goes back. This is the Reiner model of IOL which is being implanted and dialed into the bag. Throughout the procedure, we can see that the AC is firmly formed and there is no fluctuation. Another model of single piece IOL is being implanted and this requires more maneuver in dialing. However, the AC is still tightly formed without any fluctuations. The cannula can be fixed to the limbus by a bolster, which will make the surgeon free to use both hands in situations such as utilizing the rotating type of IOL injectors. This cannula can be used in small incision cataract surgery as well for hydroimplantation. In this video, cannula is inserted from the side port and rigid single piece PMMA IOL is being implanted into the AC through the tunnel. Some surgeons perform small incision cataract surgery for complicated cases like small pupil, hard cataract, and implant foldable intraocular lens. In such situations as well, this cannula can be utilized. This is a case of toric IOL implantation. IOL is implanted into the bag and dialed according to the toric axis marks. Here the advantage is that there is no need to remove the viscoelastic and chances of post-operative rotation of lens is less. Why not the AC maintainer? Well, AC maintainer has a specific use, which is to maintain the AC. However, hydrocannula can be utilized as a second instrument as well. In hydroimplantation, the IOL unfolds slowly according to the glass transition temperature. However, under viscoelastic, there is faster unfolding of IOL. Hence, our cannula can be used for IOL manipulation, such as the opening of haptics, avoiding the flipping of IOL, and manipulation in toric IOL implantation, which cannot be achieved under the AC maintainer. Here is one example in which it is seen that after implanting the IOL, the haptics have not unfolded. Here both the cannula and the dialer are used to manipulate so that the haptics open. Similarly, this cannula can also be used to anchor and avoid the flipping of intraocular lens. To conclude, cannula helps in smooth implantation of IOL. It is the first of its kind which can be used in both phaco and MSICS. It avoids post-operative visco-related complication, reduces the surgical time, and at the same time both hands can be used to implant the intraocular lens. Thank you.
very beautifully presented. I think hydroimplantation is a very good method. You know, you don't inject visco, and especially that you showed during the toric lens, where you have to go underneath the lens and then remove it.
This is the new cannula I have designed. Actually, those who use coaxial IA, it is useful for them.
Yeah.
So it can be used, those who use coaxial IA probe, and also it can be used in SICS. Actually, it is not phaco IA probe. This is the new design I have made.
So it becomes more easier to do.
Yeah, it becomes more easier and also very cheap. It costs around 250 rupees. Reusable stainless steel.
Okay.
Thank you very much.
Thank you.
Dr. Hari Krishnan, presentation is ready.
You ready with
He is going to present a shaky head with a stable surgeon.
So I'm an anterior segment surgeon. So this is one case which I want to show you. It's very shaky. It's not the camera, it's the patient. So this patient is an 86-year-old patient with a lot of comorbidities and Parkinsonism. So we operated both her eyes. She couldn't help move. We wanted to look for a GA, but she was unfit for whatever Malampatti classification the anesthetists keep on talking about. So we decided to go ahead with the topical surgery in this case. The interesting part is whenever a patient is shaking, if you tell the patient, ki mat hilao, they will move more. So the background is basically, ma'am, you're looking fantastically fine. Just look straight, look straight. And you get that lull point in between, at which point you have to do your actions. So it's out of the field sometimes. See, the microscope field is more than the camera field. So I can see more. It's done at a lower magnification. But this is the amount of movement in this patient. So the second eye was also very similar. We operated both the eyes very safely and nicely, and with a very good outcome. So here if you see that it's basically the patient is just running away from your cannula, running away from your this thing. So in this situation, I don't like to go for any direct chop or anything. It is just old, taut, trench, break, and this. And you need to have a fine grip sometimes. There are situations where you can, with a good grip, you can always. The completion of the rexis is, as you know, it's a very crucial point in the phaco. So there, I held the patient tight and it went off fine. So this is a case where your heart rate jumps to 200, but still you have to do it. The patient is having an issue in vision. So that's it. So completing the entire rexis with a cystotome. Actually, this surgery is sped up in 2x speed to fit the video presentation time. So you can just imagine it slightly slower, but still the movement is very significant. So whenever there is a major movement, see, in case of Parkinsonism, the movement always happens in bouts. So there will be intense movement and then there will be a lull period. So during that lull period, you try to manage your steps whenever the movement is reduced. And this is a kind of patient where you don't promise the patient emetropia, you don't promise the patient that I'll give you trifocal accuracy, because even IOL power calculation is going to be a challenge. In this kind of patient, if you are able to give an aided vision of 6/6 and a safe surgery, that's it. That's the main target aim for this. So with the rexis completed, I would say that most of the work is done here, because once you can complete the rexis, you have a CCC, you are stable, you can do any somersault inside to a large extent, and you can get away with it. So here the incisions may not be the perfect incisions, but yes, it's an incision with which we can go ahead. So this is the lull time when the steps are being done. So here the patient is at least looking straight. We would prefer to take these cases under GA, but what happens is any patient at that age, and there are a lot of other issues which are there along with, cataract is just one of the issues. the patient will have other comorbidities like CVA, diabetes, and COPD. So because of these reasons, it's very difficult to take this case under GA also. The anesthetist will tell you it's ASA 4, ASA 3, and then you suddenly, as a surgeon, it's your decision that what you want to do or your level of risk taking. So the same old-fashioned trenching and dividing, no fancy steps, no other, no. Now, in terms of surgery, what I realize is everybody has got their comfort zone. I operate around 40-50 cases in a month. So according to that, it is, so in that 40-50 cases, with that also, I normally don't like many variables. So whenever you're operating, assistant is a variable, microscope is a variable, phaco machine is a variable, patient is a variable, new IOL is a variable. So try to minimize all variables whichever you can, and in these kind of cases you need a very good assistant, very good setup.
Can we stop?
Yeah, sir,
Just a minute.
So I'll just skip to the last. So this is the lens, and here the IOL is in, the case is done.
Thank you very much. I think it was a nice idea, but one question, because there is a head nodding already there. So what is the problem of giving periburbil block so that at least eye is stable?
Sir,
you don't under topical. So why under topical?
Sir, in periburbil block, the reason being that the cardiologist was very chary about, sir, isme lignocaine aap peribulbar doge, we'll have to stop this, stop that. There was a lot of fitness issues. But here, what happened is the patient was confident. So we were ready to give a periburbil block. We were ready to give a subtenon, whatever is required. But I was more comfortable doing it in topical, sir.
Maybe in expert hands it's okay, but for beginner I think better to go for peri in such situation.
Sir.
And maybe some sedation also can be given rather than GA. If you give some sedative drug with the help of anesthetist, then I think things can be
slightly better,
easy for the beginners or maybe
actually, sir,
inexperienced.
this surgery took 30 minutes, and the video that you see is double speed. Okay.
You have done excellent job, but
sir,
it is just suggestion. Yeah.
Sir.
Thank you very much. Thank you.
I think your plan B should be keep your plan B ready, that you know, yeah, because once I think the Rexis is the most important thing. Once you have done with the Rexis, I think 70% of the case is done. So if the Rexis goes away or something happens, then you have your, you can convert the case, or you have your vitrectomy ready and all those things.
Sir, see, there's no shame in saying that we should be ready to convert.
Yeah.
There's no shame in saying that. So if a cataract surgeon says I had done 100% phacos in my life, I never had to convert, then it's either he's not giving the facts out or he has never operated.
Exactly.
Thank you very much. I think we can call next speaker, Dr. Amit Kumar Mahajan. He is going to show us Never Say Never Again.
So good afternoon everyone. So in this video, as you all know that lot of things has been said and done about the management of the posterior polar cataract, but the still mystery continues. So in this video, I will try to show some of my complications which would have.
Yeah. Dr.
Amit Mahajan.
Serial number 3rd. Serial number 3rd.
अभी डाउनलोड किया था
है कि नहीं है?
Not working.
अगर
Okay.
I think we can continue with the next speaker, then we can.
Maybe you can just check it there. You can check it there.
Dr. Bhavesh Saha. Is he there? He is going to present about Enlighten the Hidden, a novel technique of identifying the Schlem's canal.
Good afternoon everyone. I am going to present a video presentation on novel technique to identify the Schlemm gland. Video please.
In conventional trabeculotomy, accurate localization of Schlemm canal is the key to successful surgery. Abnormally stretched limbal anatomy in buff thalamic eye makes it difficult to identify, or may not be found in 1/3 of case at all. primary congenital glaucoma, with an horizontal corneal diameter less than 13 mm, the axial length is less than 23 mm, the anatomic abnormality of Schlem's canal is usually not significant, facilitating its easy identification during the operation. Surgical limbus is 1 to 1.5 mm wide zone, and it is divided into anterior narrow grayish-blue band representing the trabecular meshwork which is overlying the corneal lamellae, and posterior white sclera. The junction of these two band is landmark of Schlem canal, and can be explained by saying, where whites meet blue Schlem wait for you. The second tips if presence of one or more perforated vessel entering the area of Schlem canal. And another tip is slight depression at the area of Schlem canal. Advanced primary congenital glaucoma with an horizontal corneal diameter greater than 14 mm is usually associated with a significant anatomic anomaly of the anterior drainage angle. The abnormally stretched anatomy of the limbus in these patients frequently makes it difficult to clearly identify the white-blue junction and lumen of Schlem's canal. There are high chance to creation of a false passage with a probe either anteriorly or posteriorly, and high possibility for suture misdirection into the suprachoroidal space, if using 6/0 proline. The illuminated microcatheter, which has the potential to incise the angle 360 degrees and more safely allowing early identification of misdirection. Due to high cost and non-availability of illuminated microcatheter in India, we innovated new technique to identify the white-blue junction and Schlem canal by 25-gauge light pipe. By illuminating anterior chamber with 25-gauge light pipe, it is easy to differentiate blue and white junction even in very thin sclera, and junction was marked. Radial incision of 1 to 2 mm length is made over the Schlem canal region, until the external wall of Schlem canal incise, indicated by ooze of aqueous, or aqueous mixed blood. Before introducing trabeculotome, light pipe is being introduced into Schlem canal to confirm the right tract. Light pipe guide us inadvertent entry into anterior chamber. It is repeated in both sides. Lower arm of trabeculotome is introduced into the canal once 95% of trabeculotome within the canal. It is rotated into the antechamber over the iris. Minimum resistance is felt. It is repeated on other side.
In advanced case of primary congenital glaucoma, having abnormally stretched limbus, Schlem canal can be identified by using 25-gauge light pipe. Thank you for your patience listening.
Thank you, Dr. Bhavesh. Very nice surgery. I think you made things very easy to understand this part.
Yes, sir.
Initial voice was from
It is the computer generated.
computer.
Yes, sir. It is a computer generated voice, sir. I have converted my voice to computer generated voice. It is a software.
AI technology. It's an AI technology.
So there is no need of any getting a permission from them.
Okay. Sir,
Some copyright.
I think it is acceptable, sir.
Is it allowed? I
It
don't
is
know.
allowed, sir.
Like maybe somebody's voice. How can you take somebody's other voice?
It is computer generated. It is allowed, sir. In computer.
It's allowed.
Okay.
Thank you.
Thank you.
Anything can happen. Thank you.
Thank you,
Nice
thank you.
presentation. So we call on the next speaker, Dr. Ankit Agarwal, and he'll be talking on conquering hypermature intumescent cataracts, a double rexis method.
Hello everyone. My topic for this video is conquering hypermature and intumescent cataracts.
We all know an intumescent cataract is a very big challenge for youngsters as well as senior surgeons alike. The rexus is the most important part in this. So this is one of my beginning cases when I was just learning how to do the surgery. I did not know what will happen. Stain the capsule, put in a viscoelastic. And as soon as the nick was made, the Argentina flag sign appeared. So I started thinking how to avoid it. Saw some videos, lectures of others, like there's a needle aspiration technique, there is a spiral rexus technique. So I found this technique which I am employing the most easy. In this, I stain the anterior capsule and fill the AC with a high density viscoelastic like Viscoat or an Indian counterpart of it, which contains sodium hyaluronate 3%. Then a smaller axis is made in the center using the acetone. Now using IA, the nucleus is debulked, the cortical matter is aspirated out. This is done so that the intralentricular pressure has decreased now. Now I can increase the rexus size using micro rexus forceps. So by employing this method, I reduce the chances of my rexus running out. Same thing can be repeatable for all kinds of intumescent cataracts in which we find that there are chances of rexus running out. Same thing done here, just a nick, the fluid aspiration occurred. Again filling the AC with viscoelastic and making a smaller rexus in the center. Using IA debulking and then increasing the rexus size. So what is important here is that we should be able to little bit press the nucleus with our probe. Never put the irrigation probe inside the back complex. The aspiration probe should only go inside because irrigation probe, if it goes inside, the intraventricular pressure drastically increases and sometimes the capsular blowout occurs in the posterior segment. So even after taking all these precautions, sometimes we may end up in the running out capsule like this. So to prevent a wraparound, we should always put a nick on the opposite side. This reduces the intraventricular pressure. Now finish the rexus as best possible. Now you can do phaco with a safe parameters, a low parameter phaco by bringing the nucleus in the AC and using all the methods to prevent endothelial damage. Thus, using high density viscoelastics are important to prevent running out of the capsule.
Very well presented. Intumescent cataracts are always the challenging cases. I mean, like normally what I do is I make a spiral rexus. You go
That's
and
what.
you keep on, it's something like that.
Yeah.
You keep on enlarging it,
Three
and then
most common methods: the spiral rexus, the double rexus, and the needle aspiration. There is the one needle aspiration technique.
Yeah.
So I found that when doing spiral rexus, in my hands I do not get good control, because when at the end when it is reaching the periphery, it runs out at that time. So I try to do this.
I think you can even use the high molecular weight viscoelastic. That helps a lot instead of going for the dispersive viscoelastics.
Yeah, definitely.
Thank you. Thank you very much.
Thank you, sir.
So the next presenter is Dr. Devdutt Nayak. Is he here? Dr. Gautam Singh Parwar, and he'll be talking on anterior chamber compartmentalization to retrieve the worm from the anterior chamber.
Video, please. Voice.
This is a journey from a worm in the anterior chamber to a worm in a vial. The worm was in her anterior chamber when a 32-year-old female presented to us with complaints of a web-like structure moving in front of her left eye for a month. Her visual acuity in both the eyes was 6 by 6. The anterior and posterior segment was within normal limits except a highly motile thread-like worm was found in the anterior chamber. Anterior chamber wash was planned to retrieve the worm alive, and diethyl carbamazine 150 mg BD for 3 weeks was given for an antifilarial therapy. To retrieve the worm alive, it is important to restrict the movements of the worm, for which we tried an innovative approach, that is anterior chamber compartmentalization, where we replace about 2/3 of the aqueous with viscoelastic to create a visco compartment so that the worm is restricted to the aqueous compartment only. Then the worm was aspirated in toto using a 23 gauge cannula. This surgical video demonstrates the technique of anterior chamber compartmentalization. A 30 gauge needle was entered into the anterior chamber from the limbus, and about 2/3 of the aqueous was aspirated. Then viscoelastic was injected by the same syringe to create a visco compartment. The movement of the visco wave can be seen. The motility of the worm were restricted. The needle was then taken out and a paracentesis was made. The worm was then aspirated alive and in toto using a 23 gauge cannula. The worm can be seen inside the syringe. Now it was transferred to a vial containing a balanced salt solution. We can see the worm dancing and coiling on itself in the vial. Then it was sent for a microbiological examination in a formalin solution. On the post-operative day 1, patient became symptom-free and the eye was quiet. Topical antibiotics, steroids and cycloplegics were given. The worm was identified as an adult female loa loa. The loa loa is an endemic in rainforest and swamp areas of Nigeria, West Africa, and that is why it is called the African eye worm. Its stage 3 larvae, L3, are transmitted to humans by the deer fly vectors Chrysops silica while taking a blood meal. Infective larvae, L3, matures to adult L5 in the subcutaneous tissue of the human host, after which the adult worms, assuming the presence of a male and female worm, mate and produce microfilaria. And the cycle of infection continues when a Chrysops fly takes a blood meal. Other than loa loa, Brugia malai, Wucheria bancroft and Angiostrongylus are the common parasite found in the human eye. The clinical presentation and management are almost the same. The worm can cause ocular discomfort and inflammatory changes. It can also cause caliber swelling due to the subcutaneous presence of adult worms. Regarding surgical management, the major problem is the worm is highly motile. So, there is a risk of worm loss during surgery. Parasite washout with the gush of aqueous on making paracentesis has been reported. Literature suggested paralyzing the worm to restrict its motility using chemoparalysis. But this can cause the death of the worm. The dead worm can in return release toxic substances which can cause a reaction. So, our purpose was to remove the worm alive. We proposed mechanoparalysis against chemoparalysis, where OVD's compartmentalization causes mechanical paralysis of the worm and impedes its motility, which is safe and also facilitates retrieval of the worm alive.
Almost done, sir. Almost done.
Use of viscoelastic has been reported in surgical retrieval of worms, but no one has talked about mechanoparalysis of worms by the anterior chamber compartmentalization. We used a needle to aspirate aqueous and inject OVDs instead of paracentesis to avoid worm loss while making paracentesis. We also made paracentesis in an area opposite of the aqueous compartment, which facilitates the aspiration of the worm in a controlled way. In conclusion, our technique of mechanoparalysis is easy and safe and also helps in toto retrieval of live worms, in contrast to chemoparalysis where chances of damage or death of the worms are very high. Thank you.
Beautifully demonstrated, very well captured, very well.
Excellent presentation. What was the symptom in the patient? How patient came to you?
Web-like structure moving around, moving in front of the eye. That is the only symptoms.
Patient was
Nothing, no swelling, no any diminution of vision. And since the worm is highly motile, our purpose is to restrict its movement. And usually there is chemoparalysis is suggested using some topical anesthetic drops, but we thought that we can immobilize it mechanically if we use visco in such a manner. We didn't make the paracentesis initially, just that we thought that even worm loss can occur if merely making paracentesis also. So that's why we first aspirated some aqueous and then inject some viscoelastics to create a visco compartment inside. And as it is well demonstrated that as soon as we injected visco and made a visco compartment, the movement of worm is restricted to aqueous compartment only. And then we can retrieve it very well, even alive. And it kept alive even 4 to 8 hours after retrieval.
Thank you very much. I think it was an excellent presentation.
Thank you. Yeah, what about like if you want to do a fundus examination in these cases and you dilate the eye, is there a chance that it can slip behind?
I think since it is highly mobile, it will not keep too much time behind the iris. It will come forward. So we can just wait to come it forward and then we can retrieve it.
I think we have last presentation. Dr. Ayushi is there.
Thank you.
She is going to present SF5L's made easy.
Sometimes, in-bag lenses subluxate or dislocate with poor capsular back support. In such cases, management with mere CTR or bag repair may not be sufficient. The series here presents different cases wherein such scenarios are managed by only anterior approach. Our first case shows a dislocated IOL in a patient who has also undergone a glaucoma surgery. Given the inavailability of superior operating field, we refixated the lens without removing it. 2 points of fixation are marked at 180 degrees and small conjunctival peritomy is made. An AC maintainer is used to stabilize the globe. Using forceps, the haptics of the dislocated IOL are then fed into a bore of a 26 gauge needle and brought out on both sides. The haptics are then tucked into scleral tunnels and the case is closed. This technique allows scleral fixation of IOLs without the need of making large corneoscleral tunnels. Second case demonstrates SFIOL technique for foldable lenses. The existing dislocated IOL is explanted from a corneal tunnel. A small cut in the IOL is given to allow for easy explantation. After this, a foldable 3-piece IOL is injected in its place. The haptics on both sides are exteriorized using forceps and 26-gauge needles. This technique allows implantation of foldable SFIOLs. This technique allows for implantation of foldable lenses as SFIOLs. The third case demonstrates extraocular needle-guided insertion technique for rigid IOLs. The existing IOL is first explanted through a corneoscleral tunnel. After that, an anterior vitrectomy is performed and all capsular bag adhesions removed. A 26-gauge needle is inserted into the eye 3 mm from limbus behind the iris and brought out from the main tunnel. The haptic of the 3-piece IOL is then fed into the needle externally and brought out through the sclera. Similar process is repeated from the other side. Feeding of haptics into the needle bowl externally allows for easy visualization. Similar to the last cases, the haptics are then inserted into the sclera and conjunctiva sutured. Our last case shows a dislocated foldable IOL. The lens is gently dialed into the anterior chamber and delivered out using a small clear corneal tunnel. An AC chamber maintainer is then placed and remnants of bag removed. After a complete careful anterior vitrectomy, a foldable IOL is fixed using Gore-Tex sutures and 4-point fixation. The sutures pass through the haptics externally and the lens is then folded and passed through the corneal tunnel into the anterior chamber. After gently dialing the IOL into place, the suture is tightened and tied. All cases described here show simple yet elegant ways for SFIOL implantation with minimal manipulation and only anterior segment approach, allowing anterior segment surgeons easy approaches to manage complicated scenarios.
Very nicely done. Beautiful surgery.
Thank you.
Thank you. There good innovation. Thank you very much. Thanks a lot.
Thank you.
Just wanted to know what was that device which you used when you externalized that haptic to plug that haptic.
So a 26-gauge needle and an IOL holding forceps. That's
No, there was a device through which you plug the haptic.
To insert the haptic?
Yeah, you insert.
It's in
that
a
is
26
usually a
gauge
rubber band
needle.
only. You can use 220 encircling band also.
Yeah.
So anything you put it on.
You
the
engage it
haptic,
there so that you don't lose it.
so that it doesn't slip to band.
That's just any silicone rubber you
Yeah,
can cut.
yeah.
Even IV line drip you can cut and insert it.
Good. Nicely done.
Thank you very much. I think with this we come to the end of the session. I thank all the presenters. Thank you very much. And special thank Dr. Manish also. Thank you.
Thank you so much.